everyone, I'm here to talk about this week's class leadership discussion with my partner Jamie. So my part of the assignment was to read chapter 5 and chapter 16 in the book and summarize it. So I'm going to talk to you guys a little bit about that and then pose my question. So both of the chapters that I read were about ABA in more of a health-based population. So I think that usually when we think about ABA and when we think about behavior analysts, we are seeing articles and studies that deal with people with developmental disabilities, individuals with autism, and populations like that. But ABA actually has a lot of far-reaching studies and history in the health aspect. It's just not as widely known, and there isn't as clear of an audience for it. So kind of what they summarized in chapter 5 was that ABA really deals with what matters most to people and society, and physical health and wellness, is a really big part of that, especially because, as they stated in chapter 5, chronic health conditions affect over 50% of the population over 18 of the United States. And there are like a variety of health problems that are addressed in these ABA studies focused on health and wellness, like asthma, cystic fibrosis, several other disorders. But what's really tough is that for those ABA researchers that deal with the health field, it's really hard for them to find kind of like a niche or a home for their research, because one of the problems is that if they publish in the ABA journals, it's not going to be seen by those health professionals that they need to be seen. But if they publish in the health journals, they don't really have that home base of ABA, of behavior analysis, to support them. So it's kind of been tough for those researchers to find where they should publish. They don't know if they belong in a medical journal, if they belong in an ABA journal. They're kind of like wandering around trying to figure out where their research fits in. Which kind of actually really reduces the number of people that see their research, and especially the number of people who even know this research goes on. So I've been in classes for a while. I'm taking ABA classes. I'm taking special ed classes. I'm in an ABA-based workplace, and I had no idea that there were health studies involving ABA. Which, once I know that, it seems like duh. But at the time, I just didn't know that this happened. So I'm kind of like a prime example of that, where I'm reading the ABA journals and I'm not seeing this health research. But, some of it might be applicable to me. Like if I was a medical professional, I would want to be seeing this, and I'm just not really seeing it. So in the first chapter, there were 3 articles or studies that they discussed. One was on pediatric neurology and recurrent headaches. One was on distress during dental procedures in children, and one was on voice dysphonias. So I'm just going to summarize really quick these 3 articles, and then I'll go into chapter 16. The pediatric neurology recurrent headaches study was to deal with young children and adolescents who were dealing with recurrent headaches and how that kind of affected their daily life. And the researchers had 3 main questions: whether the treatment they proposed could be streamlined to a home-based rather than clinic-based management. Their second question was the extent to which contingency management of pain behavior was an important factor for the success of the treatment. And their third research question was whether treatment could be successful with tension headache sufferers as well as migraine sufferers. So kind of their intervention was that participants self-monitor daily changes in pain parameters, and then they also had parents report how they respond to children in pain and non-pain. And then they taught patients biofeedback management of autonomic dysregulation, which kind of, just to shorten that and simplify it, they were trying to increase the hand temperature and the blood flow of the participants, which is shown to lessen symptoms of a headache. And this was a biobehavioral study, so they were looking at both sides of it, kind of that environmental piece and the biology piece. So for the first part of their study, during the treatment, the patients were taught thermal biofeedback in the clinic-based setting, and then were asked to practice in the home. And they were asked to use that biofeedback or the monitoring the temperature in their hands when their pain first occurred. And then the treatment also required the parents of these young participants to use social praise for their child when the child was using self-regulation skills after the biofeedback, and also to discourage isolation or withdrawal. So if the child had a headache and didn't want to participate or go to school, they were to encourage them to go to school and not let them escape different activities. They were also given several pain management guidelines that were outlined for them to follow during the course of the study. The parents were told, in part to do not help the child cope, do not offer medicine. If the child is staying home from school, they should be treated as sick. They should stay in bed. They should not get to watch TV. They should not get to do anything fun, even later in the day when the child, feels better and is no longer suffering from a headache. They should still be treated as if they're sick. So there were several pain management guidelines that the parents of the participants were given to follow. They did a multiple baseline design across 3 groups of children. The children were aged 7 to 12, with both the biofeedback piece and the parent component. So they found that there was a reduction in self-reported pain and medication use, along with a reduction in school absences when they did this study. So the second component that they targeted was to isolate the impact of the pain management guidelines given to parents and see the efficacy of that. So for this one, they did a randomized clinical trial. They had 27 children ages 7 to 18. One group was just given the thermal biofeedback strategies, and the other was given the biofeedback strategies along with the parents given the guidelines and asked to adhere by those when dealing with their children who were suffering from the headaches. So this component of the study found that all of the participants increased their peripheral blood flow and practiced the biofeedback at home. The peripheral blood flow, again, is the temperature in your hands. But 4 times more children experienced clinically significant reductions in pain and improvements in adaptive functioning when they were also given the parent pain management strategies along with the biofeedback. So 4 times as many children in the group with both components experienced clinically significant reduction. And then just going along with that, out of that group that had the pain management strategies for parents and the biofeedback, 1/3 of those participants were headache-free at 3 months, compared to 0 in the other group that just had the biofeedback methods. 0 of those groups were headache-free at 3 months. So they kind of determined that self-regulation alone is a strategy to, show reductions in pain and practice the biofeedback, but it also needs to be reinforced by the environment, and those self-regulation strategies need to be reinforced by the parents to really have a well-rounded change in the behavior. They also did an additional study just to see if those results could be replicated by less experienced behavior analysts and also in an uncontrolled clinic environment. So they did a multiple baseline design across 7 kids ages 8 to 15. And this showed that the package was implemented successfully with clinically significant results, even in this different environment and with people who were less experienced in the field of ABA and applying this treatment. So that kind of showed, that this is a strategy that can be applied throughout, different applications and in a home-based setting along with a clinic-based setting. So the second study in chapter 5 that I looked at was dealing with students who went to the dentist and showed disruptive behavior. So the students who were, sorry, I lost my train of thought. The participants who were shown to participate in this study had a history of disruptive behavior at the dentist, whether that was biting, gagging, some of them were vomiting. Some actually had to be restrained during dental procedures. So the researchers were looking for a way to decrease these disruptive episodes during the dentist so the student or the participants could access good dental care. So kind of their question and their intervention was to evaluate an intervention designed to take advantage of the child's motivation to escape the dentist. So in the beginning stages of this study, an FA was run to determine the intensity of disruption and which procedures at the dentist involved the most disruption. Data ended up being taken by an independent observer who codes all occurrences of physical and vocal behavior that's disruptive in 15-second partial intervals. So when the participants were being calm and quiet, laying still, had their hands down, were allowing the procedure to happen, they were reinforced by repeated 10 to 15 seconds of escape where there was no dental procedure whatsoever going on. And these were brief periods, no more than 15 seconds, but they were repeated throughout the entire dental procedure. It was a multiple baseline design with 5 kids ages 3 to 6 who had been referred because they were incredibly disruptive during previous dentist visits. And it showed a marked reduction in disruptive behavior and distress when contingent escape or the repeated 15 seconds of breaks was implemented along with escape extinction. So that part was that when the students were not being cooperative, when they were not being calm, when they were not being quiet, they did not get to access those periods of escape. So the dentist would continue doing the procedure no matter what until the participant was lying there calmly and quietly, and then they would get to access those 10 to 15 seconds of escape. So during this original study, there were several issues that were brought up, mostly by the dentists themselves who were participating. One major one was that the dentist said the delivery of the intervention was too time consuming. Another concern was that the escape extinction, so following through with the procedure no matter what, the dentists were concerned that would upset parents and also possibly be a liability issue for them. Another issue that was stated by the dentist was that maintaining good treatment fidelity required such a high response effort from the dentist that the dentist did not feel that he was delivering quality dental treatment anymore because he was so distracted by trying to implement the behavior treatment. So kind of the solution the researchers came up with was to do another study where they did a non-contingent reinforcement, so a fixed time schedule of just non-contingent escape. They started at a fixed time interval of 15 seconds and lengthened the time when fewer disruptive behaviors occurred. So they used a motivator on the dentist's arm to kind of let him know when he needed to give this non-contingent escape, which they thought would be both easier for the dentist to implement and then also would not require the dentist to use that escape extinction procedure they were concerned about. And the dentist could really concentrate on their dental care because they just had a little beep at their wrist that told them when they should implement the procedure. So this second study showed a marked reduction in disruptive behavior. It was a multiple baseline design with 5 disruptive kids again, kids that were referred for their previous disruptive behavior. There was a third additional study that was a federally funded randomized controlled trial. They used 151 kids who were not disruptive. They were just everyday average patients. They were ages 2 to 9 in this study. One group was given the usual method of behavior management that dentists use, and then the other group had the fixed time interval schedule of breaks and escape from the dental procedure. And this randomized controlled trial was proven to significantly reduce, or the fixed time interval schedule was proven to significantly reduce disruptive behavior, and dentists were shown to be able to manage the delivery without impacting their dental care. So this I thought was a really interesting study because it used all those components that I'm familiar with, NCR, fixed time schedules, delivering reinforcement, escape extinction, that I use with my students in like a developmental disability aspect in a school setting, but they used it with dental care with neurotypical children. So it definitely, was a lot of terms and strategies that I'm familiar with, but done in a completely different way, and it was shown to be effective. And I definitely see how this could be applicable to really wide populations, because even children who are not shown to be incredibly disruptive at the dentist, it's still not an enjoyable experience. It's hard for the dentist, it's hard for the child, it's hard for the parent. So I definitely see how this study could be really applicable in a lot of different settings and populations. The third study in this first